Thank you, Emily. That was wonderful. I don't know why I suddenly became Dr. Dietz when you always call me Hal, but that's okay. Anyone have questions for Emily? I'm looking in the chat and I don't see any. Mary Roman, do you want to ask your question?
Sure. I was wondering if you would have similar results in the mouse model that has a less lethal phenotype.
With regard to the spironolactone monotherapy?
Well, with regard to all of the results that you presented.
Yes, we have seen similar findings in the mild model.
Thank you.
Shane?
Sure. So just coming from, I'm a pediatric cardiologist like Hal, and what, you mentioned after these results, by the way, I think they're very exciting. You presented it beautifully, and it's really, I know the data last year was talking about hydralazine plus spironolactone, but I think it's very attractive to think of spironolactone as a monotherapy because it's so well tolerated. Why did you not say trial in children as one of the possible outcomes of this?
Yes, so that's a great question. Thank you for that. So I think, let me go back to this slide. So we did perform a trial, like I had mentioned, with the spironolactone monotherapy initiated prior to weaning. So prior to puberty, the onset of puberty. And I think that the reason we don't suggest it as quickly in doing a clinical trial in children versus adults is simply because the protection afforded by spironolactone was much more dramatic in adults based on the mouse work. So it would be a good place to start in adults to see that improved survival in patient populations.
Okay, thank you.
Mm-hmm.
If I could just add to that, so it appears that there are molecular events modulated by hydralazine that are relevant prior to puberty that are not addressed by use of spironolactone. So I do think that a trial in children or young adults is warranted, but it might require some sort of combination therapy. The first inclination is to have a proof of principle in people at an older age. All right. We have a question from Xavier.
Yeah, thank you very much, Emily. Very nice presentation and results. I have three small questions. The first one was relative to Spiro dose. Which dose did you use? Because there is a dose effect in terms of association with the androgen receptor. So it might be different according to that.
Yes, that's a great question. So we treat our mice with spironolactone at a dose of 100 milligrams per kilogram.
Okay. That's one of the problems when we go after that in humans, since actually the correspondence with the dosage used in humans is somewhat difficult. And second was you showed, if I understood well, a very strong effect of a combination of Spiro plus hydrochlorothiazide. If I'm right, how do you explain the complete protection of this B therapy? It was hydralazine, not hydrochlorothiazide. Okay, hydralazine plus Spiro. Okay. And did you measure blood pressure along with spironolactone?
Yes. So we did measure blood pressure with spironolactone treatment, and spironolactone did not decrease blood pressure in our mice.
Okay, thank you.
Tristan?
Yeah, thank you. So I wrote the question in the discussion in the chat. First question is, maybe I can put on my video, right? The first question is about the J93AD wild type mice model. So if I remember well, the median survival weight was 40 days. And you mentioned that you, in the second part of your talk, that you treated the mice at 60 days compared to mice treated at weaning before. So it would mean that you only treated the survivors, which less than 50% of the mice. Is that correct? And question 2 is, how would you explain the absence of predictive effect when Spiro has been done at weaning in females?
Yes, great questions. So you are correct that I did a trial with spironolactone. I'll pull it up here. Initiated after puberty, so 60 days old. Yes, we do recognize that starting this trial of spironolactone after puberty is indicative of treating mice that have made it through puberty. So we wondered if we would see, all of the mice would survive, because we have seen a death in all of the vulnerable mice, but that is just not the case. As you can see in orange, we still see death in our mouse model in both males and females, and about 40% of mice have still shown that they are vulnerable to aortic rupture during this time period. So yeah. And what was your other question? Your other question was addressing females in this trial?
Yes.
Yes. That's a very good question. That's something that we need to look into further in terms of what's going on at the molecular level using biochemical readouts.
All right, thank you.
Mm-hmm.
Peter.
I had, one of the questions was, do you know what the mechanism is when, what you're doing when you are looking at the survivors in this case? And one of the questions about that is, the group has published data on survival on different genetic backgrounds in the mice at all. And do you know whether the drugs interact with the background at all, or how they do?
Yes, so those are great questions. So I believe your first question was regard to the mechanism of the protection afforded by these drugs. And we see high ERK and high PKC activation in untreated mice. And when our drug trials show a success in terms of affording protection in our mice, we see an attenuation of PKC and ERK signaling.
Does that mean that in the ones that don't survive, you don't see it?
Generally, we do readouts on generally on mice that have made it to the end of the trial. Mm-hmm. And I'm sorry, what was your other question? It was
there are genetic background effects, different mice strains that don't respond in the same way, don't have the same natural history.
Yes. So Caitlin Bowen, who's going after me, is going to discuss some background differences and some effects of that, but I don't have any knowledge of any interaction of these compounds with the different backgrounds.
So I think we're going to have to move on because of time. But if people will include their questions in the chat, I will encourage all the speakers to go back to those questions and try to answer them directly. Thank you, Caitlin. That was lovely. Questions from the group?
Really interesting.
I'm not seeing any written questions. Does anyone have a question that they'd like to offer verbally? Do you have a question?
Yes, hi, this is Mitra Spandiri. I'm sorry about the background noise. I'm driving. Very excellent presentation. Thank you. I have a quick question regarding to what we know in ED patients. Do we know if the phosphatase activity in these patients by any means have changed?
So that's a good question. We haven't looked at phosphatase activity, but we have looked at patient samples, vascular tissue from people with VEDS that had repair or replacement of an artery for one reason or another. And we find significantly increased PKC and ERK activation in those tissues. I don't have the data here to show you, but it suggests that even in patients with VEDS that this pathway is particularly relevant.
Okay.
I'm sorry. I was just going to say that sounds like a wonderful thing to ask, but there might be some technical hurdles. So we would need fresh vascular tissue that's preferably predisposed but not diseased. So we don't know what we would see in the context of acute dissection or rupture, for example. So that might be something as a community that we can think about how we would potentially obtain those types of tissue samples.
Thank you,
Al. Shane, did you have a question or just a comment?
No, I was just complimenting. She did a wonderful job presenting this, and the coalition of these pathways is really exciting for therapeutic strategy.
Yeah, definitely.
And Xavier, you have a question.
Yes, I just would like to congratulate the work is very interesting. What do we know about MAP2K6 expression in terms of at the cellular level, in terms of the arteries, either in the media or the adventitia, for example? And second, has it been analyzed maybe as a gene modifier, possibly in your Marfan syndrome mouse or in human?
Yeah, that is really excellent questions. So for the first question, we haven't looked at like adventitia versus like smooth muscle cells in terms of where the expression is or what arteries. I think that would be a great next step. And interestingly, in Marfan syndrome, and this could be a whole conversation, it could last a whole day, MAP2K6 expression actually seems to be detrimental. So everything is the opposite in Marfan syndrome. And we think really specifically that this is probably related to where the pathology is. And this might come back to your other question. So in Marfan syndrome, we often see aneurysms really only at the root. And in VEDS, that's something that we almost never see. And so there could be a question of MAP2K6's role at different locations in the aorta.
Many thanks.
Indeed, when we did unbiased mapping of the major modifier in Marfan syndrome, there, in contrast to this experience, 129 is overtly detrimental, and knocking out MAP2K6 is fully protective. So it is the exact opposite. We believe that it relates to the embryonic origin of vascular smooth muscle cells and how they respond to MAP2K6. But as Caitlin mentioned, that would be a very long conversation.
Very interesting, thank you.
Okay, any other questions? If not, I think we need to move on. All right, our next talk is by Nicolo De Backer from Switzerland, and the title is Drug Repositioning Added Value of Celiprolol and Pravastatin in Vascular EDS. Thank you, Nicolo. Questions from the group? Shane.
Oh, hi, thank you so much for the presentation, Nicolo. It was really nice. My question was, I know that you assessed bisoprolol, but that's a second generation beta blocker. And I think some of the argument about celiprolol is that it's third generation and has some vasodilatory effects. And I was wondering if you had assessed any other third generation beta blockers that we commonly use, like carvedilol or labetalol, which, although it's a different mechanism than celiprolol, might have vasodilatory effects as well.
Yes, indeed we have. So this data is still also preliminary and unpublished, but we tested an additional third generation beta blocker and did not observe any impact on the aortic rupture force. And it was also the same treatment setup. So 4 weeks of treatment between the ages of 4 to 8 weeks.
Okay, thank you.
Tristan?
Yeah, this is a short question. I probably missed one slide, but what mouse model did you use for your drug testings?
Sorry, what was your question?
Which mouse model was used?
Oh, the mouse model published by Smith. So originally described as truly haploinsufficient, but it has an in-frame deletion of exon 33 to 39.
Shireen?
Thank you, Nicola, for presenting. Can you explain to the non-cardiologist, what do you think is special about celiprolol? I don't have a clear understanding of what is different about celiprolol.
Well, so I have actually a slide for this. So this is of a different unrelated paper, but there is some preliminary cell culture data showing that actually celiprolol will decrease the expression of UPAR, thereby decreasing activation of plasmine, and plasmine is involved in activation of MMPs. And additionally, it has also been shown that the treatment of celiprolol, again in cell culture, increases the expression of TIMP1. So that could be a possibility. However, there's no solid data on that, or that in vivo it's like this.
Mary Shepard? Mary,
yes, thank you.
There you
go. Nicolo, great work. I just think this is so interesting, and I actually love the opportunity to have, Caitlin and Hal and Nicolo all together on this session, because, I was struck by, I think, data maybe not presented today, but previously published, that Caitlin did not see a benefit with celiprolol in the mouse model of vascular EDS. And then Nicolo is seeing that there's a benefit to the rupture force. And I would have expected that the rupture force would correspond to overall survival. And I was wondering if any of the three, I guess, not necessarily just Nicolo has to respond, but if you have any ideas to maybe what's the explanation for the discrepancy we're seeing?
So I'm just spitballing in that sense. We used a third of the dosage used by the group of Professor Dietz. Could be a dosage dependent adverse effect, but actually I don't know about that, but this is one of the main differences. The background for both is Black 6 Jackson, so also for the 2 glycine substitution models. This could be a possibility.
So we looked at a 10-fold range of dose of celiprolol and saw the deleterious effect on survival in both the severe and mild vascular EDS mouse model. The other relevant piece of information is that so far, with all of our therapies that create an overt survival benefit, ERK inhibitors, PKC inhibitors, 129 background, there is no association between survival, collagen content, or biomechanical strength of the tissue. We've done that testing similar to what's described here, and we do not see any improvement in the biomechanics of the tissue in the face of a full survival for close to the mouse full lifetime on the 129 background. So Nicola, did you look for a survival benefit in your study? We didn't see those data.
Yeah, so we terminated these mice at 8 weeks of age, and for celiprolol, all mice survived. To be fair, also for losartan, we just had one spontaneous death in the treatment group. However, obviously, this could also be that losartan is effective in reducing the blood pressure, and there's never a critical blood pressure reached, which would then induce rupture. But so, for example, for bisoprolol, we had like 40% death. Obviously, this would be really interesting to do like a more long-term study. However, as we have also seen over the past years, the mortality really kicks in between these 4 to 10 weeks, probably also related to sexual maturity. But later on, mice rarely die due to aortic rupture. So yeah,
I mean, Xavier, your group has presented work at the genetics meetings that losartan is dramatically protective in your model. So there seems to be model-specific differences. But again, that would be something worth trying to reconcile, that, once again, a protective agent apparently is not associating with a change in vessel wall structure or biomechanics. It's really suggesting that something else, suggesting to me that something else is the major determinant of rupture risk.
Yeah, so actually what is also not known yet, I mean, in this mouse model we use, if the rupture is really correlating with a blood pressure. So is there really a blood pressure peak and the order rupture, or is it just basically a mouse physiological blood pressure, and at one point, due to movement or whatever, a rupture will be induced? So that's actually also still an open question.
Okay, are there other questions? I'm trying to catch up on the list. Caitlin? Oh, Peter, I'm sorry, Peter Byers. Peter, are you there? Peter's question was, would statins interact with any of the pathways discussed by Caitlin or Emily?
Yes, so I mean, statins, so we have three, or basically there could be 3 different modes of action for statins. I have just a slide for this one. So dissection of the prenylation pathway actually showed that treatment with pravastatin reduces isoprenyl modification of RAS, and therefore a reduction of membrane-bound RAS, resulting in a reduction of TGF-beta mediated signaling and reduction of MMP2 expression as well as activity. The second possibility is obviously the dose we used was shown to significantly reduce cholesterol levels. So serum cholesterol is significantly down, and cholesterol is obviously required also for androgen hormone generation. And therefore it could actually also reduce androgen receptor signaling and thereby have this added value in VEDS. So that's also a possibility.
All right, we have almost eaten up all of our break time. So I think we need to move on, but once again, I'll encourage Nicolo to be available for ongoing questions. So our next talk is by Rebecca Sorber from Johns Hopkins. And the title is High Dose Vitamin. Thank you, Becky. Questions from the group? Mary.
Great, thank you. Again, I think, Rebecca, this is fantastic work. It comes up all the time. Of course, the human data for vitamin C and VEDS is just really lacking in terms of power. I think we need clear answers here. And one thing that I was thinking about in terms of clinical applications is, do you feel that you would have that same dramatic response to withdrawal if the withdrawal of the vitamin C was at a later time and age?
That's a good question. I don't know that you necessarily would. I would like to emphasize, I don't know that it's necessarily a rebound effect so much as just a complete loss of protection. They never seem to, or at least we don't have the numbers to say that there is a rebound effect to the point that the survival is worse than untreated. I don't know. That would be a good thing to investigate. In theory, at the time that it's withdrawn, meaning genetically, everything should be on the up and up. However, they are still quite small and they're still growing up until, let's say 50 or 60 days of age. So it is a good point that we did withdraw the vitamin C where the mice are still in a growth phase. So it would be a great question, and I would like to know the answer to that. And that's something I think that we should definitely pursue in the future. When mice reach their maximum weight is probably a point at which we should investigate withdrawing vitamin C therapy.
Maybe also when they're post-puberty.
Exactly.
That's a good idea.
I agree.
So I'd try to make sure you can get my email. I'd love to follow up on those results with you.
Absolutely.
Okay, and Shane?
Oh, sure. Thank you for the work. Again, it's quite interesting. I just I noticed in your background when you were comparing males and females, it looked like the mortality between the males and females was very similar, which is unlike the other models of VEDS in which the males have earlier mortality. And so I don't know if, it made an even more striking difference when you had the males and females next to each other and you showed your controls. Those curves look almost identical. And so I was just curious if you had any postulation why there might not be the sexual dimorphism in the controls.
There is a sexual dimorphism in the controls. It's a little hard to see based on the side-by-side, but the males do have a more dramatic death, and they do have a faster onset of death. There is a sexual dimorphism, but it may just not be as evident when you don't have a combined curve to compare them to.
It just looks a lot more subtle than I think the rest of the data. I mean, you see it a little bit here, but it just looks much more subtle.
So remember the dimorphism really jumped out when you used hydralazine to prevent the early death. That's when it was remarkably striking that males were doing worse than females. But what Becky's showing here is pretty representative of what we see in mice that have received no treatment, that males do a little bit worse, but it's not a very dramatic difference. So relating to pre-pubertal events, probably.
Okay, thank you guys.
Any other questions?
Yes, I would like to ask a question.
Sure.
I'm a little bit confused. Is tensile strength a factor in the etiology of vascular rupture or not? Because Caitlin stated clearly that in her studies, there was no difference in the tensile strength. And now we're seeing excessive cross-linking may have. The Swiss studies certainly show that there is an impact of tensile strength. So where do we stand on this issue?
I think that the right thing to say is that we need more information. There certainly do seem to be mixed outcomes. I did not specifically measure the tensile strength of the aortas of these mice to see whether or not they were stronger. That would be a good thing to pursue in the future because I think that right now we have enough mixed data to suggest that we don't really know. I mean, our past data, as evidenced by Caitlin, is such that we don't believe that tensile strength is a major factor, but certainly with ongoing research from multiple different groups, I think that that's something that we should continue to revisit because it could certainly be contributing.
And using an assay that is essentially identical to what was described from the Zurich group, we see a reduction in tensile strength in vascular EDS mice, but we see no improvement with any of the pharmacologic or genetic interventions that lead to overt rescue. Here it's interesting that females benefit, but males don't, yet both show increased collagen cross-links. So again, suggesting that there is more to the story, something more to understand. So I think the right answer is that it's complicated. More work needs to be done to understand it. All right, I think we will move on. Thank you, Zach. Are there questions for Zach? I don't see
Hal,
any.
I have a question.
Yeah, sure.
So Zach, good presentation. Really appreciate it. Wondering if you could just restate the male-female differences and as it relates to type of exercise, just your outcomes there.
Sure. So we find in the males that when we impose isometric exercise, there might be a potential for worsened outcomes shown on the left dashed green line.
Yep.
However, it's not statistically significant from the controls, which is the red line, the male mice that did not exercise, and potentially, a benefit, again, not statistically significant, shown by the purple line in VEDS males who did the aerobic exercise. And then in the females, we find that when we impose the isometric exercise, we find a complete protection from aortic dissection. But when the female mice are on the treadmill system doing aerobic exercise, there's potential for a worsened outcome there.
That's fascinating that it's sexually dimorphic and opposite. Leaves a lot of questions to be answered going forward, but really great questions.
Yeah, we've gone through a lot of literature trying to come up with meaningful hypotheses, and the obvious and frustrating answer from the literature is that you find information is all over the place regarding the hormonal or other effects of exercise in a sex stratified manner. So it really is hard to take away from the literature any foundation principles. That's why we're using the more unbiased approaches of just inhibiting both male and female hormones to see if that's what's making a difference. There was no sex difference in hemodynamic response to exercise. There was no sex difference in the ability to perform the exercises. So we feel pretty confident that it's not just a trivial explanation.
That's a great start on a challenging question. I'm looking forward to more of the Mouse Olympics coming up.
Let's see. Mary?
Sure, thank you. This is just very thought-provoking. The y-axis is your days exercising, but not necessarily the age of the mice. How old were these mice when you started the exercise regimens?
Yeah, so we started the exercise at weaning. So they were 21 days old.
So Shane asks, the ends are still small. Are these experiments ongoing? And the answer is yes, they are. Isometric exercise is easier to perform, so we have higher numbers. The aerobic exercise depends upon access to the exercise facility, but we are increasing those numbers. Let's see. Tristan.
Yeah, thank you. Very short question. Isometric exercise intensity here for the mouse, what would it be corresponding to human exercise, for example? Can you give us one example?
So I think one of the considerations we had was how exactly this model does relate to kind of answering the question of weight training and trying to assess whether or not there are harmful or potentially beneficial effects to isometric exercise.
So the paper that we referenced that looked at this model and determined what type of exercise this was did show that there were the same acute and chronic physiologic effects as one would expect to see, for example, in heavy weightlifting. When there's static contraction, but not a lot of change in length of the muscle. That's about as good as we're going to be able to say that physiologists considered this to be a model of isometric exercise, such as heavy weightlifting. Let's see, Mitra?
Yes, thank you. Great presentation. I'm wondering if for the protective effect that you see in the female, did you think of looking at MMP expression in the tissue, seeing if there is any difference between male and female?
we have not done that yet. It is something that we could look into.
Okay, thank you.
Okay, and Julie?
Thank you very much, Dr. Dietz. I was just struck by the difference in presentations between males and females as well. Do you have data on whether they died from dissections in similar aortic segments? We've seen some males die more of large dissections and women more with SCAD and with dissections in other arteries that tend to be smaller. Was that reflected in your mice population?
So what I can say is that the vast majority of animals, greater than 95% or so, have a hemothorax or a hemopericardium at the time of necropsy. The vast majority have hemothorax. Unlike the Marfan mouse model, we never see hemopericardium, so it does not appear to be the proximal ascending aorta. And when we can localize events based upon direct visualization, it again is overwhelmingly the descending thoracic aorta that is the site of highest vulnerability, and that is true in both sexes.
Thank you very much.
Okay, I think that concludes this session. We are scheduled to have a panel discussion, so perhaps we can take some additional questions. I would ask all the speakers to be available to respond to questions. Any questions about the specific presentations or question on the topic of this session? How can animal models be used to define mechanisms and treatment strategies?
I have a question for Caitlin.
Sure.
Caitlin, good work again. Just wondering if for sure your work sort of demonstrates some potential intervention, pharmacological intervention in the findings. I'm wondering if there's also, you see potential for biomarkers and prognostic testing from your data. I presume so, but you didn't comment on that as well.
Yeah, that's a great question and something that we've been really thinking about too, especially in our models. The outcome is death from aortic dissection, which is not really a great model. I mean, it's like a good model, but it's not really like an outcome that we might want to measure. And one of the hardest things that we have is like predicting which mice are going to dissect. And so that's definitely an active area of investigation, looking at either biomarkers in the blood or other areas in the mice, but definitely ongoing investigation. We haven't really found anything yet.
Great, thank you. Again, good work.
I mean, that certainly, Tony, is something that I hear about from many different drug companies that are thinking of investing in this area. They ask, can you describe to us a short, relatively small and definitive trial outcome that will allow us to, get into this space? And so I think that we should all embrace the challenge that you articulate. Can we come up with surrogate markers for clinical events?
Mm-hmm.
Any other questions, thoughts?
This is Peter. I just wonder, can you talk about the issues about translation directly from mice to people and what the limitations are with that, and whether there are intermediates that would be helpful and how you would go about doing that? Given the experience with the losartan trial, the initial losartan trial, and the problems with that.
So are you asking that to me or to any particular
Well,
panelist?
anybody who'd like to answer the question, who's thought about it, you guys have thought about it a lot. You could do it, Caitlin could do it, and Rebecca.
You know, as you highlight, there are challenges inherent to extrapolating from mouse studies to expected human experience. I mean, I think as commented or at least suggested by Xavier earlier, dose matters. It's really hard to translate a mouse dose to a human dose because bioavailability differs and metabolism differs. And so we use do our best to use what are considered comparable doses in mice based upon the active metabolite or the physiologic effect that you're seeking. I think the Losartan experience is informative. As you know, there have been many studies that have reported a beneficial effect of ARBs, and there have been other studies that reported more nuanced or equivocal results when comparing to beta blockers. There were dramatic dosing differences between those studies. But I think the challenge should be to go back and forth between models and humans and, do reality checks, test yourself. Is what I'm seeing here relevant to people? As was mentioned by Caitlin, we have gained access to some human specimens, and we do see the corresponding elevation of PKC and ERK phosphorylation in predisposed vessels, not acutely damaged vessels. But we got to do a lot more of that. And some of the studies that have been suggested, like looking at phosphatase activity, I was really intrigued by that question and motivated by it. I think that's the answer. I think we have to not just simply assume that there's going to be translatability. The other question is, are there a lot of effective human therapies that did not show a protective signal in mice? And the answer is no. So things that do work most often do work in mice. It's just that sometimes it doesn't go the other way. Especially when you're using a mouse model that's so rigorously developed to mimic the pathogenic events of people, using mutations previously seen in people, looking to make sure that you see pathology in the same distribution on a time scale that's relevant. For example, we are quite intrigued about the impact of sexual development and the gender biased effects that are reminiscent of what's seen in people. We got to do a lot more of that to make sure we're keeping honest.
I have another question, if I may.
Sure.
Are there any other vessels involved except the aorta in any of your experiments?
The answer is yes. We do see lesions in other vessels when when sacrifice is done, including dissections or pseudoaneurysms. The fatal event in our mouse models tends to focus on the descending thoracic aorta, but yes, we do see that there is vulnerability in other vessels.
And just a general question. Are you relying totally on historical controls?
No, every experiment has contemporary controls. So there is never reliance on historical controls.